Hi all, this is Scott and welcome back to the Neuro Knowledge Podcast. This episode will focus on seizures and epilepsy. It's likely to be a little bit longer than the prior episodes just because we spent some time really delineating different aspects of seizures as well as different diagnosis of epilepsy. We'll also be joined by Dr. Kate Hocquard a little bit later in the episode. We'll be discussing some important details that families and patients with a new diagnosis of epilepsy need to know, some common misconceptions regarding epilepsy, and also some facts regarding women with epilepsy, specifically women of a childbearing age. As always, the podcast is available at iTunes, Google Play, Spotify, and on our Facebook page. And with that, let's jump into today's episode, which focuses on seizures and epilepsy. A seizure is a brief episode of abnormally excessive neuronal discharges and brain activity, which results in various outward symptoms depending on the area of the brain involved. A generalized seizure involves an abnormal discharge affecting nearly the entire brain and really the brain surface or cortex of the brain. A focal seizure involves an abnormal discharge in one area of the brain. However, this can spread to involve neighboring areas and potentially become a generalized seizure. Epilepsy is a medical condition in which a structural or metabolic issue within the brain leads to the occurrence of multiple unprovoked seizures and will continue to do so if no treatment is initiated. Essentially, any person with two unprovoked seizures 24 hours apart, one seizure with a high likelihood of another seizure, or those with a diagnosis of an epilepsy syndrome meet criteria for a diagnosis of epilepsy. Epilepsy affects about 1 to 5% of the population, and about 180,000 to 200,000 people are diagnosed with epilepsy each year. I think there are several other important points to define before we move on as well. Seizure semiology is what someone watching a seizure sees or observes. This could be someone staring off in the middle of a sentence, the twitching or rhythmic motion of a limb, eye deviation to one side, or stiffening and then shaking of the limbs, or some combination of these. A post-ictal state is generally a fatigued and at times confused state which occurs for a varying length of time following a seizure. This typically resolves and the person returns to their baseline over 1 to 2 hours in most cases. Some people with epilepsy can have a very prolonged post-ictal state that lasts longer than this, however. Finally, status epilepticus or status is a medical emergency where someone has had or is having a prolonged seizure, typically longer than 5 minutes as the standard cutoff, and the seizure is not resolved on its own. Additionally, if someone has had multiple seizures and has not returned to their baseline level of functioning in between them, this is also consistent with status epilepticus. I think when discussing the causes of seizures, we really need to break the discussion down into seizures and epilepsies which begin in childhood and those which begin in adulthood. In children, approximately 1% will experience at least one seizure not related to a fever before the age of 18. There are a large number of causes of seizures in epilepsy in children, including metabolic, insults to the brain such as strokes or trauma, which will overlap with adults. Separately, there are genetic and neurodevelopmental conditions which often present in childhood as well. An important point to discuss regarding seizures, particularly in young children, are something called febrile seizures, or seizures associated with a fever. These are seizures which occur when a child has a fever due to an infection which does not involve the central nervous system, which are things such as meningitis or encephalitis. Typically, they occur in children from 6 months of age to 6 years old. Approximately 3 to 5% of children will have a single febrile seizure throughout their childhood, and 30% of those patients will go on to have additional febrile seizures. Of all children who do have febrile seizures, approximately 3 to 5% will go on to develop seizures unrelated to fevers or a diagnosis of epilepsy. Aside from febrile seizures, genetic causes of epilepsy typically present in childhood, with symptoms beginning anywhere from the newborn period to the teenage years. I think we could briefly touch on certain conditions which develop in each age range, keeping in mind that this is certainly not an exhaustive list of the different types of epilepsy syndromes that can present in childhood. In the newborn period, there are several benign seizure conditions, including benign neonatal seizures and benign neonatal familial epilepsy. These are seizures which are typically seen fairly early on in a child's life, usually within the first week or so. They usually then self-resolve. It was felt that children affected with these conditions generally have an overall good outcome and develop normally, hence the benign name in the name of the conditions. However, more recent studies have shown that there is a potential for a mild delay in motor skills, although children will eventually catch up with their peers. Two other conditions have a more severe presentation and poor outcome, and they are Odahara syndrome and early myoclonic encephalopathy. Moving on to infancy, this is generally any child that is out of the newborn period but is still less than 2 years old. In infancy, febrile seizures can still be seen along with the benign syndromes we just previously discussed. Two severe conditions which can present in this time frame include West syndrome or infantile spasms and Dravet syndrome. West syndrome or infantile spasms is a syndrome of severe seizures beginning in infancy. It is characterized by epileptic spasms, a particular EEG pattern called hypsarrhythmia, and developmental regression. This latter point means that children will begin to lose skills that they once had, such as the ability to walk or handle an object, etc. This disease course will eventually result in intellectual disability. Treatment typically involves a hormone called corticotropin or ACTH, which is injected. There are different formulations which can be injected either once a day or more frequently. Anti-seizure medications are often quite ineffective with this condition, although vigabatrin is a notable exception. Dravet syndrome is a very rare but severe epileptic encephalopathy with refractory seizures and developmental problems. In the majority of patients, it is due to a mutation in a gene for sodium channels, specifically sodium channel SCN1A. A child will typically have a normal cognitive and developmental course until the seizures begin. Initial presentation in Dravet syndrome usually occurs in the setting of a prolonged seizure, often in the setting of a fever. In the following weeks, repeated seizures and possibly status epilepticus typically occur. Additionally, myoclonus, which are brief jerking motions, can also be seen. The recurrent seizures are often refractory to anti-seizure medications and often require non-medication treatment, such as ketogenic diet, which we'll discuss later. Due to the large number of frequent seizures, motor and cognitive development often become fairly severely impaired following the onset of seizures. This leads to children and young adults with marked motor and cognitive as well as behavioral problems. Throughout childhood, several other conditions can also be seen. Childhood absence epilepsy is a condition where children will usually present with absence seizures around 6 years old, but really anywhere from 4 to 10 years old. The hallmark of this disorder are seizures called typical absence seizures. These are seizures with marked impairment in consciousness without really any alteration in body tone. A child will suddenly stop an activity they were performing, which is called behavioral arrest, and may appear to be kind of staring off into space. This usually lasts for 5 to 10 seconds, and there's no stiffening or shaking of the limbs, which is typically associated with a seizure. Absence seizures can occur dozens of times daily, however, they are often missed or felt to be merely inattention due to their sometimes subtle nature. They can be brought on by hyperventilation, however. Fortunately, absence epilepsy typically responds quite well to an anti-seizure medication called ethosuximide, and seizures will often go into remission before puberty. A more severe condition called Lennox-Gastaut syndrome can also develop in childhood. Lennox-Gastaut syndrome, or LGS, is a syndrome characterized by severe seizures of multiple different types, which begins in childhood. Seizures usually begin between the ages of 3 and 5, and children develop normally until they begin. As stated, the syndrome results in multiple different seizure types, including tonic seizures, atypical absence seizures, and atonic seizures. In the latter type, a diffuse loss of muscle tone in the body can result in falls. This can come on very suddenly without warning and can be quite severe and lead to fairly severe injury at times. Additionally, non-convulsive status epilepticus is often seen during the disease course at some point. There are a number of potential causes of Lennox-Gastaut syndrome, including genetic, neurocutaneous syndrome such as tuberous sclerosis, events of decreased oxygen or blood flow to the brain, meningitis, etc. Due to the frequent and severe seizures associated with the condition, intellectual disability often results. There are a large number of other conditions which also can present in childhood, including benign epilepsy with centrotemporal spikes or BECS, childhood occipital epilepsy or Panayotopoulos syndrome, epileptic encephalopathy with continuous spike and wave during sleep or CSWS, and finally Landau-Kleffner syndrome as well. During the teenage years, juvenile absence epilepsy, which is similar to the childhood type, can also develop. It is somewhat different from the childhood variant, however, as it presents around age 10 to 12 and has an increased risk of additional seizures such as generalized tonic-clonic seizures. Juvenile myoclonic epilepsy is another condition which can present during the teenage years. Typically, teenagers will have one or more types of seizures, including myoclonic seizures, which are jerking motions often of the limbs, generalized tonic-clonic seizures, and absence seizures. The seizures typically occur most frequently in the morning, shortly after waking up. They can be worsened by sleep deprivation or alcohol intake. The seizures fortunately respond quite well to an anti-seizure medication called valproic acid, which we'll discuss a little bit later in the podcast. In addition to genetic causes of seizures in epilepsy, Neurodevelopmental lesions also tend to present in childhood. These are lesions which involve an abnormality of the surface of the brain or brain cortex. During development, there can be abnormalities with the migration, the organization, or proliferation of cells which will eventually develop into the brain cortex. Neurodevelopmental lesions can be very small, involving just one small area of the brain cortex, or be more profound with an involvement of an entire hemisphere or one side of the brain. Additionally, multiple small areas of brain cortex could be involved in both brain hemispheres. These abnormalities in the brain cortex are potential seizure generators, and obviously if there is a greater area of abnormality, then the seizures or epilepsy could be more severe. Neurodevelopmental lesions can be identified with a brain MRI with specific sequences which help to highlight the brain cortex from the underlying brain tissue. Depending on the amount of brain tissue involved and the location, lesions can potentially be surgically resected, and we'll discuss this a little bit later in the podcast as well. In adults, and in particular older adults, there's a multitude of reasons for seizures to develop, and really this gets at the increased risk of seizures because of a variety of medical conditions which become more prevalent as we age. In terms of acute seizures, certain medications, particularly multiple medications and their interactions, can precipitate a seizure. This is called polypharmacy, where a number of different medications have been slowly added to a person's regimen sort of throughout the years, and then their interactions create various medical issues, with potentially a seizure being one of them. Additionally, withdrawal of certain medications can also precipitate a seizure. Drugs including alcohol use or alcohol withdrawal can also lead to a seizure. Alcohol withdrawal, depending on the level of alcohol use over time, can potentially lead to status epilepticus and be fatal in this setting. It is one of the main reasons that medical supervision is needed when quitting alcohol. In adults, particularly older adults, there is also an increased susceptibility to metabolic issues leading to a seizure. Metabolic issues include a variety of things, including infections, electrolyte problems such as low sodium or magnesium, excessively low or high blood sugars, and polypharmacy, which we just discussed. Also, head trauma can also be a precipitant of a seizure or epilepsy at any age, but given that older adults have an increased risk of falls and head trauma in that setting, it is particularly prevalent among that population. A stroke, and particularly one affecting the surface of the brain, can also lead to a seizure and potentially to epilepsy. Due to the increased risk of stroke as we age, it is a particularly common cause of seizures and epilepsy in older adults. In fact, it can be the cause of a third to a half of seizures or epilepsy in those over 65. Typically, hemorrhagic strokes or bleeding in or around the brain, strokes affecting the surface of the brain or the brain cortex, and large strokes all increase the risk or potential to develop seizures and or epilepsy. And so, how exactly do we diagnose a seizure? Well, diagnosing a seizure disorder requires obtaining a clear history of the events, what occurs with them, when they began, as well as any potential risk factors from earlier in life, such as meningitis or encephalitis, seizures with fevers as a child, or significant history of head trauma. In addition, an invaluable tool in the diagnosis of seizures and epilepsy is an electroencephalogram, or an EEG. An EEG involves using small recording electrodes which are either glued directly to the scalp or they're applied tightly to the scalp with a cap and a standard distribution across the scalp surface. These help record activity from the surface of the brain, and in particular abnormal discharges which could lead to seizures or record seizures themselves. A video recording during an EEG is also often obtained in order to record seizure semiology, which is what the seizure looks like to those who see it. Typically a routine EEG is quite brief, lasting around maybe 1 hour. For those with infrequent events, a prolonged EEG lasting several days can occur either at home or in a hospital epilepsy monitoring unit. If in a hospital and a person has a known seizure disorder, typically their anti-seizure medications are slowly reduced in dose in hopes of provoking a seizure and being able to record one while they're there in the hospital. Additionally, imaging of the brain is also important in the workup of a seizure in epilepsy. An MRI of the brain is typically performed with a very specific seizure protocol. This involves using a scanner with a more powerful magnet in order to obtain a higher resolution or a better resolution scan. Essentially, I think of it as a 4K TV versus an HD TV, where with that higher power magnet you can really get a much clearer picture of the brain. Also, there are specific sequences which highlight the surface of the brain or the brain cortex in order to identify any subtle abnormalities which could be there as a seizure generator. An additional imaging study is something called a SysCom scan. This type of scan is performed while being monitored in an epilepsy monitoring unit. When a seizure occurs, a radiotracer molecule is quickly injected, which is then taken up in the area of the brain where the seizure is occurring. A scan of the brain is obtained at that point, and then a day later, specifically 24 hours later, and the scans are then compared to one another. This allows doctors to visualize the precise location where seizures are originating from, which could potentially be a target for surgery. Now, if all these above studies are unsuccessful in identifying a seizure focus, or if there is difficulty precisely identifying the focus, then intracranial monitoring is a potential option. This is a surgical procedure where a portion of the skull is removed and then a small grid of electrodes is placed right next to the brain. This eliminates the skull and allows us to record much more detailed information and provide much more detailed monitoring to identify a focus from which seizures originate. I will say that this typically is reserved for people who have a seizure disorder which is refractory to medical therapy, meaning that they're on multiple medications at fairly high doses and yet they're still having fairly frequent seizures, either multiple per week or even multiple per day. In addition, it is typically pursued in those people who may have a small seizure focus, at least at the initial onset of a seizure, which could be surgically removed and result in a cure or at least a drastically reduced number of seizures. Now, obviously, we just touched on some potential surgical intervention for seizures. However, this is usually one of the last resorts, and so there are a large number of medications available for the treatment of seizures. They each work on one or several receptors and ion channels in the brain, and they really work to stabilize the connections between different neurons, or synapses between different neurons. They help to minimize overly excitatory activity, which could be a potential seizure generator. Given the large number of medications available, I think we'll just focus on some of the main players which are commonly used and then some of the side effects to be aware of with them. And so, one of the most common medications is a medication called levetiracetam, and Keppra is the brand name, and most people just refer to it as Keppra because the generic name is fairly hard to say. Keppra works on calcium channels and glutamate receptors. It's typically taken twice a day and started at a low dose and then quickly up-titrated. It actually has fairly minimal side effects and medication interactions compared to many of the other anti-seizure medications, which often makes it a first choice for patients with new seizures or a new diagnosis of epilepsy, depending on the epilepsy type. Its main side effect is increased irritability, or a feeling of kind of being on edge. Also, in children, this can lead to anger or violent outbursts. Another medication is called valproic acid, or Depakote is the brand name. Valproic acid works on a number of different channels in the brain, including calcium and sodium channels, as well as glutamate receptors. It is either taken 3 times a day, or with extended release formulations can be taken twice a day. The main side effects of valproic acid include weight gain, hair loss, polycystic ovaries, and decreased platelets in the blood. It can also have effects on the liver, and so usually blood levels checking liver function are obtained prior to starting valproic acid. An additional point to point out is that due to the increased risk of birth defects with valproic acid, it's typically not prescribed to women of childbearing age, just given this risk, in the hope to prevent any complications. Another medication is called lamotrigine, or Lamictal is the brand name. Lamotrigine largely works on sodium channels in the brain, but also has an effect on calcium channels and glutamate receptors to a lesser degree. The medication is introduced at a very, very low dose and then increased slowly. Once a target dose is reached, it is typically taken twice daily. However, it can take 3, 4, even 6 weeks to reach this target dose. Common side effects with the medication include double vision, tremor, insomnia, and the most severe, a potentially life-threatening rash called Stevens-Johnson syndrome. Lamotrigine is started at a low dose, and that dose is slowly increased because of this risk of Stevens-Johnson syndrome being so high shortly after starting the treatment. Another medication is called phenytoin, and it has been around for quite a few decades now. It works on sodium channels exclusively and is taken 3 times a day. Side effects include increased gum tissue or gum hypertrophy, and this is usually seen with prolonged use. Additionally, osteopenia or thinning of the bones, as well as potential liver toxicity and rash can be seen. This rash is typically not as severe as Stevens-Johnson syndrome and is somewhat different from that. Another medication is carbamazepine, or Tegretol is the brand name. It works on sodium channels and is typically used for focal seizures. It is taken twice a day with extended release formulations, and the main side effects include low sodium levels, and so they need to be monitored when someone starts the drug initially. They can also reduce the white blood cell count, contribute to liver toxicity, and again have the potential to cause Stevens-Johnson syndrome. Finally, oxcarbazepine, or Trileptal, also works on sodium channels and is typically used for focal seizures as well. Its side effects also include low sodium, but additionally include double vision and a less severe rash than Stevens-Johnson syndrome is also possible again. In addition to these side effects, I think it's important to point out the interactions between the different anti-seizure medications or other medications that someone may be taking. These are taken into consideration by doctors when choosing a medication, especially in the case of medications such as lamotrigine, phenytoin, and carbamazepine, which really work on some of the enzymes in the liver which metabolize different medications. Additionally, sometimes a rescue medication can also be given to patients with epilepsy, and this is used if someone is having a prolonged seizure or a cluster of seizures. The medication is a benzodiazepine, so usually either lorazepam, which is Ativan, or diazepam. They are either in concentrated solutions which can be placed inside the cheek and rapidly absorbed, or in rectal administrations. Obviously, given the fact that they're being given either during a seizure or during a cluster of seizures where somebody's mental status isn't quite where it needs to be, it wouldn't be safe for them to swallow, and so we need to find another way to administer these types of medications. Typically, these medications should have very, very clear instructions on when they should be given and subsequent medical attention that's required if somebody is requiring a dose of their rescue medication. I think here it's important to point out a common misconception regarding the use of anti-seizure medications. While they can be useful in preventing seizures, they do not prevent or cure epilepsy. Someone with a diagnosis of epilepsy may have great control of seizures on a medication, perhaps not suffering a seizure for a number of years even. However, it is important to point out that the potential for seizure activity is still present, and so abruptly discontinuing or stopping a medication or missing doses of the medications could lead to a seizure. Now, there are cases where someone may be seizure-free for a very long time, and a close discussion with one's neurologist may be had about slowly reducing the dose of the medication and then eventually stopping it. However, this is typically the exception much more than the rule, and so, again, a close relationship with one's neurologist is really needed. I'd also briefly like to touch on the use of medical cannabis and cannabidiol, or CBD, for the treatment of epilepsy. Cannabis, or marijuana, has numerous phytocompounds and cannabinoids within it. However, for our discussion, I think we can focus on THC, which is the psychoactive chemical in cannabis which produces a high, and CBD, or cannabidiol, which has no psychoactive effects and no high associated with it. The CBD portion has seen increasing use in patients with treatment-resistant epilepsy in recent years. These are patients for whom standard anti-seizure medications have failed them, and so they fail to control their seizures despite really high doses of the medications and multiple medications being on board at the same time. These patients will typically have numerous seizures per day and include children with conditions such as Lennox-Gastaut syndrome, Dravet syndrome, infantile spasms, amongst others. CBD is typically given as either a tincture or an oil extract. I think it's important to point out that these tinctures have no or very low THC concentrations in them in most cases. Many tinctures or extracts which are derived from cannabis will have a ratio of THC to CBD based on the product type. For use in the treatment of epilepsy, this ratio is typically 1 part THC to 10 or 20 parts CBD. And so really the focus is on getting as much CBD as possible with the minimal amount of THC. Pure CBD formulations derived from hemp are also available. Now, there have been several studies looking at CBD's ability to reduce seizures or achieve seizure freedom versus placebo, and those have had some fairly positive results. Additionally, open-label use of Epidiolex, which is a pure pharmaceutical form of CBD manufactured in the United States, has shown promising results for treatment-resistant epilepsy in children and young adults with fairly good safety profiles as well. It is important to point out that CBD should not be used in isolation as a treatment for epilepsy, and as with other anti-seizure medications, does not provide a cure for epilepsy. It is merely helping to control seizures. The use of medical cannabis and CBD should be thoroughly discussed with either your own or your child's neurologist to discuss its role in treatment and what impact it can have on different anti-seizure medications' drug levels, because it can affect those to a certain degree. Now, aside from medications, as we touched on previously, surgery is a potential option in certain people with a diagnosis of epilepsy. With a epilepsy surgery, typically the goal is a resection of a very isolated seizure focus with the goal of either complete seizure freedom or a markedly reduced number of seizures. Epilepsy surgery can be performed when an isolated seizure focus is found and it is not an area of what is called eloquent surrounding brain tissue. This means that if a seizure focus is very close to an area which functions for, say, language or movement and would result in a very severe deficit if this area was resected, then surgery is typically not performed. Additionally, if seizure focuses are seen or identified on both sides of the brain, then this can muddy the waters surrounding a decision for surgery to a degree. The overall goal with an epilepsy surgery, like we discussed previously, is to go for a cure. However, if there are seizure-generating areas on both sides of the brain, then obviously a resection of just one of them would be unlikely to result in freedom from all seizures. Now, if an individual has a large number of seizures and many of them originate from one side as opposed to the other, then surgical removal of this focus to reduce the overall seizure burden may be considered. This means that while a person will not be free from seizures completely, they would at least hopefully have a decreased number of seizures and perhaps the ability to reduce their seizure medications. Now, for those who have refractory epilepsy and are not candidates for surgery or who do not want to undergo surgery, a vagal nerve stimulator is an additional option. The procedure involves surgically placing stimulating electrodes near the left vagus nerve, which runs through the neck. This involves placing the electrodes very close to the left carotid artery along which the vagus nerve runs. The wires from these electrodes are then connected to a battery and stimulator pack, which is implanted under the skin on the left side of the chest. It's a little bit smaller than a pacemaker. The stimulator does not provide a cure for epilepsy, but can improve a person's seizure burden. The exact mechanism by which the stimulator reduces the number of seizures is still not exactly settled, but it is thought that the stimulus ascends through the vagus nerve and brainstem, leading to an overall inhibitory effect on different areas of the brain cortex and other areas within the brain. A VNS is typically effective in about 50% of patients and can reduce seizures by up to 50%. I think an additional treatment that we should discuss is the ketogenic diet. It's a non-medication option for the treatment of epilepsy and is becoming more popular amongst the general population due to the potential for weight loss and just decreased carbohydrate intake overall. It has been shown to be effective for epilepsy, however, since the 1920s and perhaps even further back than this. It is commonly used in pediatric patients with epilepsy, but can also be used in adults as well. The ketogenic diet is a very high-fat, low-carbohydrate diet with adequate protein for growth. Typically, a person will follow a specific fat-to-carb ratio while they're on the diet. Specifically, 4 to 1 grams of fat to grams of carbs, with the lowest ratio usually being about 2 to 1 in terms of fat to carbs. The diet requires very strict adherence, however, and essentially 100% compliance. This is somewhat different from someone electively choosing a ketogenic diet, where someone will break ketosis with a cheat meal every once in a while, or intake carbs and then try to get back into ketosis over several days. This is really not an option in someone using the ketogenic diet in the setting of epilepsy, because once ketosis is broken, the potential for breakthrough seizures increases. Now, while anti-seizure medications do not necessarily work on epilepsy itself like we discussed, the ketogenic diet truly is an anti-epileptic treatment. It's effective in about 50% of patients, with a reduced seizure burden being the most common outcome, but seizure freedom can also occur, and this is really the goal of the ketogenic diet. The ketogenic diet results in changes at the cellular level within the brain, which leads to improved seizure control and potentially seizure freedom in certain cases. Children and adults are typically kept on the diet for about 2 years. At that time, carbohydrates are more slowly reintroduced by transitioning to a modified Atkins diet and then an Atkins diet, while monitoring for an increased seizure frequency during this time. Obviously, the Atkins diets are a low carbohydrate diet, but usually do not result in ketosis. The ketogenic diet is quite challenging, however, particularly in children who may be picky eaters, and given the restricted nature of the diet, it really is hard getting the necessary calories and food they like into that type of diet. As such, they may take some convincing regarding eating the particular foods that are involved. Additionally, the requirement of 100% compliance for 2 continuous years can also be quite difficult and typically is a limiting factor in using the diet. Alright, all at this point, I think we'd like to welcome Dr. Kate Hocquard to the podcast. She's an epilepsy fellow who's currently pursuing her fellowship at Mayo Clinic in Rochester, Minnesota. And with that, Kate, welcome to the podcast.
Thanks, Scott.
And so jumping right into it, you see a number of patients with a new diagnosis of epilepsy, or perhaps even with just a first-time seizure. What are some important points you like to stress with them, as well as what is some important information you like them to know, especially at their first visit?
One of the most important things to let patients know when they first come to see me in the office is to reassure them that this is certainly a very treatable condition. There are many medications that are available for use, and they're all excellent, each in their own respect. Even if medications do not work, which can happen in a certain subset of the population, there are other treatments available. And every year we have new advances in technology that allow us to treat seizures more effectively. Beyond that, I also like to stress with patients that there are things that are within their control to help reduce seizures in the future. These include trying to minimize seizure triggers. The points that I like to stress with them are making sure that they take care of their bodies, get enough sleep, avoid stress, stay hydrated, don't skip meals, and most of all, take their medication as prescribed. That means not skipping doses, not taking it early or late, but staying on a routine every day. Finally, I also stress with them seizure safety. So that includes the things that we all think about, like not driving a car for whatever law exists in their state, but also things like avoiding the use of unsupervised power tools, avoiding building a fire or grilling unsupervised, avoiding heights, taking showers instead of baths, and really trying to avoid any situation in which a person could be putting themselves in danger if left unsupervised.
Excellent. And so I think, a lot of that information is really important for patients to hear, especially with the new diagnosis of epilepsy and trying to combat everything that comes along with that. Now, given your broad range of experience with epileptic patients, what are some common misconceptions you typically encounter when discussing epilepsy with patients and their families?
I think the biggest thing that people tend to feel when they come into the office is that this is a life sentence. And although seizures and epilepsy may be a chronic condition, people can typically lead very normal lives with treatment. And so it's important to remember that although this certainly can impact people's life, it does not mean that they can't go on to have a normal life like everyone else. Beyond that, another misconception that I have found is that some people, particularly in younger patients, find that there's stigma associated with their classmates or with other people in the public that this could be contagious or that this is hereditary. That's not the case. Typically, a patient that has seizures does not have other family members with epilepsy, and it can't be passed to anyone else through any other means.
Great. Thanks, Kate. And now, just as our final point, would you mind discussing the diagnosis of epilepsy in women and specifically some of the challenges that are faced by this unique patient population?
Certainly. We know from research that patients with epilepsy face increased possibility of having unplanned pregnancies, and that potentially relates to the fact that our brains that are mishardwired that can cause seizures can also lead to sometimes impulsive judgment making, and that can include the increased risk of unplanned pregnancy. We also know that there is a delicate interaction between birth control methods as well as the medications that we use for seizure prevention. There are some seizure medications that can reduce the efficacy of our birth control, and we also know that there are some types of birth control that can affect the potency of our anti-seizure medications, and so it's very important for you as well as your neurologist to be aware of this and to be mindful of these interactions. For those that are considering pursuing pregnancy, there are medications that are considered very effective against seizures that are also safe for babies and for mothers during pregnancy. However, it's important to discuss these in advance with your neurologist as well as with your OB-GYN to make sure that you're on the right medication and that you have the correct supervision as you enter into a pregnancy.
All right, Kate, thank you very much for joining the podcast.
Thank you, Scott.
Thanks. Take care. Now, before we go, I think there's several other important points we need to discuss as well. A phenomenon called SUDEP, which stands for Sudden Unexplained Death in Epilepsy, should be discussed really with all patients and families of patients with a new diagnosis of epilepsy. It occurs in approximately 1 in 1,000 adults and 1 in 4,500 children with epilepsy. Now, the exact mechanism of this is not fully understood, but it's felt that there is a combination of respiratory, heart or cardiac, and brain effects at play. Although not necessarily in this order, it is felt that a seizure leads to respiratory depression or a decreased drive to breathe. a decrease in heart rate or an abnormal heart rhythm is generated, and a global suppression of brain activity, which in combination is ultimately fatal. Amongst those with epilepsy, there is an increased risk for SUDEP in those with poorly controlled or refractory seizures, especially those with an increasing frequency of seizures. This is really the most important risk factor. Additionally, those with predominantly generalized tonic-clonic seizure types, poor medication compliance, young age, and an early onset of seizures, along with male gender, are also at an increased risk. Additionally, when someone has had a seizure or there's a new diagnosis of epilepsy made, safety considerations should also be discussed. Now, typically following a seizure, or really any unexplained loss of consciousness, someone should refrain from driving for a certain period of time. This largely depends on the state or territory in which you live. I currently live in Minnesota, and so if someone has had a seizure here, typically we ask them to refrain from driving for 3 months, and really refrain from driving for a 3-month period with no further events before they return to driving. Alright, I think that brings us to the end of another episode of the podcast. I'd like to thank you again for joining me and tuning in. Also like to thank Dr. Hocquard for coming on and discussing her expertise with epilepsy as well. I think we were able to address a number of different misconceptions regarding a diagnosis of epilepsy, as well as misconceptions regarding anti-seizure medications and their effects on an overall diagnosis of epilepsy, as well as hopefully some misconceptions regarding medical cannabis and cannabidiol or CBD use for the treatment of epilepsy, which is refractory to standard medications. Hopefully you're able to join us again in a couple of weeks when we'll be discussing Parkinson's disease. Till that time, thank you again for listening. Take care. The Neuro Knowledge Podcast is meant as an informational resource for patients and their families. It's not meant to diagnose or treat any medical condition. It's not meant as a replacement for medical evaluation. The views expressed in the podcast are solely those of the speakers and do not reflect those of Mayo Clinic or its subsidiaries.